get going?
Yep, it's just about to start now. There we go.
Thank you very much. So welcome everyone to our first virtual improvement forum. As you know, we haven't had an improvement forum for some time now. I think back in March with the COVID response, we stood them down. We're still limited on how many people we can get together in one room, so we're trying virtual for the first time, and we'll test it and see how it goes. But welcome, thank you for everyone for joining us. I think in terms of Academy team, as you see us speaking, we'll hopefully have our background so you can recognise us. If you've got a comment, please use the comment box. If you want to interrupt any of us and have a chat about something, just put your hand up and I will bring you in. So welcome introductions. My name is Maria Riley. I'm Associate Director of Strategy and Improvement for the Trust. I will let people introduce themselves as they speak, but the agenda for today is an overview of how improvement supported our COVID response with the Royal Academy of Improvement team. Stacey Burton, our improvement facilitator in the team, is going to give you an update on bringing improvement ideas to life, her first few weeks in improvement. And then we're going to have a spotlight on improvement, so exactly how we used to do things in the forum pre-COVID, with some presentations about improvement that's been happening across the trust. I'll talk about a little bit about training, and then we'll close with sharing and celebrating our success. So if we get going into the first section, Victoria. So just to kind of give you an overview, we have been really busy with improvement, even though it kind of hasn't been visible through the improvement forum. I hope a lot of you have been involved with that and seen the work that we've been doing. So just to kind of give you an overview of how that's played out, I feel really strongly that we did something very unique as a trust in our response to COVID. Back on the 16th of March, which feels like an absolute lifetime ago, I remember having a conversation about how we were going to approach things, and what we agreed was that we were going to stand down our improvement programme as it stood. We were going to bring the whole Royal Academy of Improvement team together, and the team would work hand in hand with our operational staff to support the operational response. So what we really focused on was kind of one aim, which was maintaining our cancer and our outpatient services. We didn't do what a lot of trusts did, which was stand down the activity and just cancel outpatient appointments. We said we really wanted to keep them going. So we set ourselves the challenge really of mobilising years worth of change in a few weeks. So some of the highlights that we did, we focused on redesigning clinical pathways and converting every appointment into an outpatient, into a telephone or a video consultation. So that meant in the first couple of weeks, we were ringing every patient and telling them that it would be a telephone consultation, and then quickly followed by kind of sending out thousands of letters to our patients and changing everything over. Whilst we understood that wasn't necessarily going to be a clinical consultation in all circumstances, if the patient needed to be seen face to face, we felt really strongly that it was better for a patient to have a conversation with somebody sorry, I'm just trying to mute people. To have a conversation with somebody and to have reassurance about what was going to happen and how they could escalate if they had an issue with their clinical condition, and how they could get back in touch with us. We rapidly deployed IT. I think some of our improvement team felt like IT professionals at times, making sure clinicians had laptops, they had kits that people could continue to work virtually, and a lot of our clinicians continue to do that off-site. We implemented a clinical assessment service, so triage for all of our 2-week wait referrals, so we could prioritise patients and still get them into the trust for urgent diagnostics where the clinician felt that was important. We implemented virtual cancer MDTs, so we could continue decision making without clinicians being in the room if clinicians were working from home, so we kept the decision making going for our cancer patients. We had daily meetings to oversee our response, and we reported daily into the COVID-19 kind of governance arrangements in terms of escalation of the incident. So we had really quick decision making. So next slide, Victoria. So this is what we did in 4 weeks. In the first 4 weeks of the response, we went from 4% to 86% of our appointments being delivered virtually. We had an ambition in terms of the long-term plan to deliver 30% of our outpatient appointments virtually over 3 years. So we made a huge amount of change, and a massive collective effort went behind that in terms of operational teams, improvement teams, clinicians all working together to make that possible. We move on, Victoria. So these are just a couple of slides that sit in Model Hospital, which is a way that hospital data all goes in there, and we can have a look at where we sit with our peer trusts. So these couple of slides, I appreciate you can't see them too much, but we'll send the slide pack out. These show that in August, we were 3rd in the country in terms of up there delivering virtual appointments, if you take out the 2 trusts that weren't our peers. And that supported a position in Joined Up Care Derbyshire, where we are. We were at that point in time in August, we were 2nd nationally behind Lincolnshire. Just move on for me, Victoria. Thank you. So that's brilliant news. But what you can see here is the restoration and recovery impact on our improvement. So you can see that the delivery of non-face-to-face appointments starts to come down quite steeply as we move into restoration and recovery, and we see more people back on site. So one of the things we're really heavily focused on at the minute is the review of the variation and looking into clinical specialties and understanding that the variation is clinically appropriate, and that we haven't just reverted back to kind of old ways of working. It's clinically appropriate that those patients need to come back in. Just next slide, please, Victoria. Thank you. So what we're really focused on is the true redesign, which is going to give us sustainable improvement. And it's about redesigning our clinical services for sustainable change, modernising our operational ways of working, and ensuring that we've got a site and IT infrastructure that supports the delivery of those new ways of working. So our current key work streams in terms of the academy work are primary care, so deployment of advice and guidance so that GPs can manage patients in primary care, and patients don't arrive in an acute hospital setting if they don't need to. Clinical pathways, so new pathways in the new virtual world, and implementing a sustainable future service model for our clinical services. Non-face-to-face, so we made great progress, but what we want to do is deploy and maximise use of video consultations, and Richard will talk you through a little bit of that work in more detail. Workforce models, so adapting workforce in line with new pathways. We can't ignore the fact that what we've done is deliver a new service, and it needs new workforce models around it, and Anthony will talk you through a little bit more detail on that. And then none of that works if we don't have robust IT infrastructure to support our new ways of working, and we don't reconfigure and modernise our estate. So they're the key priorities that as a team we're currently working through. Next slide, please. Thanks, Victoria. So in line with anything improvement, we've redefined our improvement aims. This is just one of the objectives that we've set ourselves. So this is showing our outpatient activity for new outpatient appointments and follow-up appointments. And this is demonstrating that we've set our ambition to achieve above the national benchmark going forwards. Whilst we know we're bringing more face-to-face appointments back, we're absolutely committed to holding on to and locking in the improvement, and we've redefined our improvement aims around that. Next slide, please, Victoria. Another thing that we've kind of done is learnt from our improvement approach over COVID. So we've had very structured programs before. We established a plan for the year based on an annual improvement plan. What we've learned from our COVID response is that shorter improvement cycles really work. And there's a quote from NHS Improvement there around how that enables you to break it down into manageable chunks, maintain momentum and energy around it. So going forwards, we've adapted our improvement approach, and we're really learning from that and working now within 90-day improvement cycles, and then resetting our ambition after the first 90 days. Next slide, please, Victoria. So just in terms of clinical pathways, just delving into one of those areas a little bit more, Luke, who hopefully most of you know, was planning to be here, but unfortunately can't. So I'll just take you through a slide with a couple of examples of things that we're working on. So patient-initiated follow-up is a key work stream for us. This is around patients not needing to being able to access the services when it's most important for them. So what we've previously done is have very scheduled, regular follow-ups. So a patient comes back every 3, 6, 12 months. And sometimes patient doesn't need to come back, so that results in DNAs. But sometimes it also doesn't allow the patient to come back when they really need the service. So patient-initiated follow-up is a key way for us to ensure that patients can re-access when they need us, but don't feel a need to just come to a hospital appointment that's not adding any value for them. So that's a key work stream. Referral assessment service is something else that we're rolling out at the moment. So we learned from COVID in terms of triaging and all of the referrals that came in, and making sure that urgent patients could go to the still get into services. We learned from that the real value in that upfront clinical triage. So we are implementing currently a referral assessment service across all of our services. So what this means is a GP who would previously have been able to see a choose and book slot and book a patient in while they were sitting with them. The GPs can't see those slots anymore. So the referral is made in by the GP. One of our consultant or clinicians triages that and who looks at the referral. And then there are a number of options. So that could be dealt with by advice and guidance. So the clinician could contact the GP and say, actually, I would do X, Y, and Z to manage that patient, and they don't need to come into the hospital. It could be that we refer them straight into a diagnostic rather than an outpatient appointment, because they would have needed that diagnostic and they can have it first before they see the clinician. It could be that they go into a different service. So very often GPs will refer in where they think the patient should be seen, but that's not necessarily the best place. And then the further options, if we do need to see the patient, is the clinician can choose whether that's a face-to-face appointment, a video appointment, or a telephone appointment. So we've got a range of options, and we're only in month 1 of rolling that out, but we're hoping to see really good benefits for our patients in terms of ensuring that they only come into the hospital when they really need to, but also that they come into the right service first time. Another area where we're really focused on is putting services into the community wherever we possibly can. So 2 key areas currently being worked on are community pessary clinics, with the Matt and Guiney team working through that, and then the other one with community echocardiograms. So we are going to be delivering a service, hopefully within the next month, of echocardiograms in one of our rural primary care sites at the Grange, which is a huge step forwards in terms of putting services out into the community and patients being able to access them locally. If you just, thanks. So I'll hand over to Richard, who'll talk to you a little bit about digital.
Hi, yeah. So I want to spend a little bit of time talking about video-based appointments. And it's probably worth going back to the beginning of, before COVID even happened, we were using Attend Anywhere in the Trust, and the Trust was one of 10 pilot sites for the use of Attend Anywhere, which is one of a number of platforms which offer video-based appointments. And we piloted it very successfully in women's and men's health services, with lots of positive feedback from staff and patients, but video appointments themselves still represented less than 1% of all appointments that were offered on an outpatient basis. When COVID first started, clearly with lack of face-to-face appointments, there was more importance given to video. We've tried to roll out initially to the services where it was felt would have the biggest benefit, which is difficult to judge because clearly some services you would imagine would be very helpful for, and others it's less clear. But as we've gone along the journey, we've realised that some of the assumptions that we make around where video is important are not necessarily true, and vice versa. So where we're at now is we've extended the aim of the project so that it's a lot wider, and what we're aiming to do is that all clinicians really should be in a position in the future to offer a video-based appointment if it's clinically appropriate, in the same way that we're able to offer face-to-face or telephone, which is clearly a large project, and we're only part way through it. As you can see on the narrative on the left, at the minute we've got 24 services fully set up. They're using Attend Anywhere to varying degrees, and we know that some services will use it way more than others because video lends itself to that patient group or the type of appointment more than others. And we've got a further 14 in various stages of setup. There are a number of other services that we'll go to after that. The feedback from staff and patients, particularly patients, has been overwhelmingly positive. There's some graphs in a minute which will show you. In terms of how patients feel, as you can see from there, nearly every patient that's completed a survey so far has rated their experience as very good or good. It's 92%. If you go to the next slide, Victoria, yeah. So, I mean, the sorts of benefits that they're talking about are more convenience to them in the sense that they're not having to take time off work to come to the hospital. The length of time that they're in the hospital for or having the appointment is a lot shorter. So in some instances, patients were in the hospital for an appointment that might only last for half an hour in total in terms of how long you're with a clinician for, but it might have been in and around hospital for several hours. And they're reporting various cost savings, and again, the average is between £5 and £10 per appointment. So if we were to just go back to where we've offered it to, the graph's moved on now, but the amount of time that we're spending on video consultations is increasing. If you just go back to the first one, Victoria, please. And you can see that where we were in March, right at the start of the pandemic, the graph just registered pretty much zero. We've increased quite rapidly, and we seem to have stabilised at sort of 70-ish hours per week. I imagine that on the one hand, that could continue going up as more services start to use video. Equally, it may stabilise at that level as we've got more face-to-face appointments, but you can see the increase that we've had. In terms of where it's being used, if you go to the next graph, please, Victoria, yeah. It's a bit difficult to understand at this point which services it's likely to be more appropriate for than others. You can see that the ones that are using it most are paediatrics or therapy-based. But that said, some of the other specialties such as urology and trauma orthopedics, haematology, preoperative assessment, they're services which are not currently using video and will be in the future. So it'll be interesting to see how that graph changes. There's clearly examples such as CAMS, who were set up quite late on in this process. And since I originally did these graphs, they're now the second highest users. So you can see that some services, video appointments are very, very helpful for. And just the last thing in terms of examples. So at the start, when I said we made assumptions about areas that would use it well, and then it turns out it's not as necessarily as helpful. Dermatology is perhaps a good example. So at the start, it was felt that being able to see being able to see a patient's skin would be helpful on video, and it turns out that the video quality is not quite good enough because we need an image. Whereas other areas, diabetes again is a good example, where they've helped a patient to fit their own insulin pump at home by video, and clearly in the past that would have been a face-to-face appointment. We've also gone into palliative care services, and Dr. Brooks, who I don't think is on the call, has given a really good example of a patient who had a lot of investigations in his primary investigation clinic and then moved to London during the pandemic, couldn't have a face-to-face appointment, and Dr. Brooks had a really successful video appointment, informing the patient their diagnosis and then plugging them into services in the London area. So if anybody has any questions about video, or after this forum they're part of the service who isn't currently using it, if you want to contact me, hopefully I'll be able to help you there. Thank you.
Perfect, thanks Richard. Anthony, you're going to talk us through the work around workforce models.
Oh yeah.
Sorry about that, we're both in the same office, so we have to turn one off and turn one on, so apologies for that. So what we've found during, I think outpatients in general, even before COVID came around, through the NHS benchmarking data that we had, our outpatients had always seemed to be, I'd always seem to have quite a few more staff than a lot of comparable organisations, and we've never really been able to understand what those working models were and why we ended up that way. So one of the things that COVID brought out was that we need to start working differently, and the way in which we move patients through the trust, how we set out our suites, has to change quite drastically. Some of the work that I've been involved in that led to the workforce work is the allocation of suites within suite 1, 2, 3, 4. We found that we actually didn't have enough estate to bring the capacity back that we wanted to bring back. So we were finding on certain days we didn't have rooms available for clinics, for consultations. We were scrabbling around trying to find clinic space. And so what we've realised is that the workforce models that we've employed before, whether that be the medical model, nursing model or AHP model, we need to revisit and work out what we actually need, where we need, and let it be activity driven. So we're trying to find a workforce that is based around activity. And if that means working outside of normal working hours, it's something that we're trying to focus on. So some of the models that have been utilised in other areas, in other trusts, like clinics. So in our trust, we have a lot of clinic availability after 5 o'clock and on the weekends. And what we've started to trial is looking at can we run clinics from 12 until 8 o'clock at night, and then have that activity spread out through the day, and some clinicians and nurses, doctors, HPs can have as many clinic rooms as they want, and we find a skill mix that suits that clinic at that time, and we can push more activity through. In the current climate, what we're finding is that trying to start looking at workforce models when we don't know what the next week brings is always going to be very difficult. But we're trying to plan from the front door, so a workforce that manages the flow of patients. So we change the way in which patients come into the hospital, and we change the way in which we actually look after them once they're here. And the workforce plan as such for outpatients is currently working with a lot of other trusts that have set up their outpatients as a single point of entry. So we have an outpatient unit that has its own management structure, and then so it'd have a matron, some kind of administrative lead, and we would have it as everyone came in through there, and no one area has a area for them. It's that we have an open trust, and that on Monday you might have certain activity in suite 1, but on a Thursday it's in suite 5, and we try and open it up and work it like that, and that we make sure we've got the staffing models to improve that activity, so we've got people doing the right things at the right time, and that we're maximising people's ability to do stuff. Because I think we push people to work to the top of license, but then don't utilise them at the top of that license. So it's looking at what activity we can push to those people in areas where we're either not pushing enough activity through, or we haven't returned back to pre-COVID levels, or where we can actually take on more work, where we actually open ourselves up and start bringing in more work from hospitals that haven't been able to plan and organise as well as we have. And so that's the workforce element of outpatients and the 90-day plan in a nutshell.
Thanks, Anthony. Sorry, Sean, I'll let you go.
Okay. Hello, my name's Sean Sumner, and I'm the Cancer Pathway Improvement Lead. I'm going to talk you through our Cancer COVID-19 Review and Reset Plan. From March through to July this year, the Cancer Leadership Team worked with clinical teams and operational teams to develop a responsive plan to maintain cancer services throughout COVID-19. We initiated a social distance face-to-face clinical and operational COVID meeting to discuss implementation of new guidance and actions to operationalise these. Our cancer manager, Nina Morgan, implemented a weekly patient tracking list meeting to ensure that there was a safety net for all our cancer patients and clear actions on what the next steps in their pathway were. We were successful in gaining access to COVID capital funding for transperineal biopsy kit, endoscopic ultrasound kit, e-bus, and breast specimen radiology system. So if we take a look at the top left-hand box end, So far, we haven't had to cease any of our improvement work due to COVID-19. Let's move across to Amplify in the top right. We continue to build on the clinical triage step that has taken place during COVID to develop clinical assessment services, better known as CAS. This will help with primary care education and collaboration to ensure referrals are relevant and we have all the patient information we require. We will continue to roll out Attend Anywhere across our tumour sites, accessing telephone and video consultation and working with clinical teams to offer patient choice in how they receive their diagnosis, including breaking bad news via face-to-face, video or telephone. We will work with IT to optimise virtual MDTs, which are vital when Chesterfield and Sheffield hold joint MDTs. Beneath, we have Restart. We will work with the colorectal CNS team to continue the development of the remote monitoring module within our cancer software programme, Infoflex, as well as implementing this model for the prostate team. We will collaborate with imaging on the diagnostic steps in the bladder pathway, which is also a Cancer Alliance priority. We will implement treatment summary templates for haematology, then moving on to breast, dermatology, lungs, and any remaining specialties when they are ready. Travelling across to the left, Do Differently, we will be using a number of mediums to deliver care and information to our patients. For example, the breast team now offer an end of treatment telephone appointment rather than bringing the patient back into the trust. Prostate self-management workshops to include a video option. Lung straight test GP and patient video information videos have already gone live, and we're also in the process of producing patient information videos for both colorectal and upper GI. The Macmillan Information Centre provide a COVID support telephone line, and we continue to look at new delivery models for all services. And finally, we are piloting Macmillan patient involvement roles. Thank you for listening. If you want any more information, you can contact any of the clinical leadership team. Thank you.
Thanks, Sean. I'm going to move on rather than take questions. I can't see anything in the chat box to answer to, but Stacey, do you want to do how Working for Improvement has been and how you're supporting people with bringing improvement ideas to life? And don't do any less time than you were planning to do, because I can shrink things later at the end.
Take it off if you want to, anyway.
It totally took me out of my comfort zone. So I worked on Ashover Ward, and we were very passionate at making improvement for patient cares. So these are a few examples that we used on the ward. So one of the questions that I was asked was, how do your dementia patients truly know who's looking after them? So the ward came up with the idea of putting photographs in the bed spaces so they could see the nurses. Some of the other improvements, we did a ward book which tells them everything that they need to know, and the work's continued since I've left. Bex has at the moment just discovered some magical drinking cups for dementia patients to increase hydration. So that's just a new project that I'm working on with Bex on Ashover Ward at the moment. Next slide. So what I've discovered while I've been doing this role is that everybody really does care, and everybody puts the patient at the heart of everything we do. But what I did find is that we all do it on our own. So the medical patient is very well looked after in medical, the surgical is very much the surgical. And actually the patient's journey crosses over so many different fields, even just within one admission. So I think that this is sort of where I've come in. Next slide, please. So I see myself as the bridge between divisions, because I'm not particularly linked now in with surgery, medicine, nursing. I can sort of work fluidly anywhere. We can really sort of reach the patients better. One of the projects that I'm doing at the moment, I was approached by Robinson Ward, about fractured neck of femurs, and if you break it down into care divisions, it was basically getting the patient out of ED and into a bed quicker. And what could we do? So a lot of the work is surrounding, orthopedics are taking on a lot of the work, but the real benefit other than the patient would be the length of stay in ED and releasing the ED bed. So that's all in really early days yet. So we'll watch this space. I should bring that back to you. So what next? So I want to empower, listen to staff who want to make changes. I want to support the teams through changes, and I want to bring the patient into it and listen and engage with patients to improve their experience, because they're the people that are laid in the bed experiencing it, and just to ensure that we give the patient the service that they want, not what we want to give them. So any ideas, any improvement, you know, give me a ring, give me an email. I'm happy to chat to anybody. Am I doing this bit as well? So we've also done the Academy newsletter that will be coming out shortly, and this is just a summary of improvements that we've done, the improvement team, and we'd be really interested in everyone's good news stories. What are you doing, and to include that, because one thing that we don't do is share, improve the patient experience and the staff experience. So this will be coming your way soon. Read it, it's beautiful. So if you've got any ideas, this is how you can get in touch, or you can email me directly. I'm just Stacey Burton. No dots, no numbers. There's only one of me. Thank you.
Thanks, Stacey. We'll bring the those details back up at the end as well and leave them on the screen so you can take them down if you didn't grab them then. So this is one of the brilliant bits where anyone can come share some improvement that's being delivered across the trust and tell us and share what's being done. So Sam, are you going to talk us through Falls work?
Yeah, I'm here. So I just wanted to give a bit of a background about myself to start with. So I've done 5 years at the Trust all in total, 4 years as a physio, and then my year as a falls practitioner. My role at the moment is working with Rachel Wyman, the falls lead. We're all part of the inpatient falls safety group, which I'll also talk a little bit about. My main sort of bits are collecting data, and then from that data identifying themes and if there's you know, common trends that are happening out on the wards. A lot of teaching and education with staff, and then looking at improvements and leading on them to make sure we're doing the best things for the trust. So the inpatient falls safety group, we're like a subcommittee of the QDG, and we support the trust in taking actions to reduce the risk and incidence of falls and harm from falls. We need to also make sure that we're complying with like the Royal College of Physicians and the National Audit of Inpatient Falls as well. So it's a lot of different members, from matrons to falls champions and therapists. There's a lot of people involved in the meetings, and we circulate our improvement plan between us all, and ideas of how we can achieve certain goals. And it's just a really nice sort of forum where we all get as much give as much input and receive input from each other. So it's a great forum for us. I also have the ward falls champions. We're just getting these started at the moment. A few of them are due to attend the meetings with us, and it's mainly to assist on the wards and help me, because I'm only one sort of person, to support any changes that we're going to make, and start doing the teaching out onto the wards. So that's just a bit of an intro. Next slide, please. So when I started as a falls practitioner, I was doing the falls sequin. That was my initial set of improvement that I was doing. So it was all about line and standing blood pressures, looking at mobility, and then also looking at medication reviews on patients. Now that's just a quick slide that we did 4 different quarters, and you can sort of see they're in different colours. The red one is the one I'm sort of most proud of. The red one is the line and standing blood pressures, and that went up, as you can see, throughout the quarters, and we got a really good result at the end. So that was where I saw the biggest improvement. So that was where I kind of got my confidence then that when I got this role, we've sort of moved on and looked at bigger and better projects. So just a quick overview of the projects. So we're looking at medication reviews on patients. So looking at the medications that are related to falls and how we might be able to alter or change any of those medications to put people at less risk. The flat lifting equipment is something we're also looking at getting. We've worked quite hard on a case of need for that, along with the manual handling leads. So that's coming through. Updating the falls policies in the handbook, so eventually these are going to be hopefully accessible on the intranet a bit better than they are at the moment, but then just making sure that everyone's aware of the new changes to the policy and the updated bits, and then the handbook needs to be a little bit more user friendly, so we're looking into that. Managed to put some alerts on Medway and worked with receptionists so that they can alert me if we've got repeat fallers that come in. Mini swarms happening on the wards, so when a patient has a fall, to get the people together that were around at the time, they would then look at what we did well, what we could improve on to try and limit the risk of that patient possibly falling again. We are looking at possibility of bedside vision checks because we don't always know if our patients can see properly, which will put them at risk of falls. So trying to get that instilled out onto the wards, updating the low bed guidance with, you know, what we've got in place at the moment, making sure that's all up to date. The Fall Safe project is quite a biggie. That's happening on Ridgeway ward that we're doing as like an exemplar ward. So some of the projects that I've mentioned will be rolling out on there. Along with many others that we've kind of tailored for our trust to make sure it fits with us. But for example, education about supervised bays and what that means, and education about like the call bell, and if a patient can't use the call bell, what are we going to do instead? Because obviously these are the sort of things that are putting our patients at risk, expecting them to know how to use something that they might not have the cognition or the ability to do. So looking at the bigger picture of how we can keep someone safe. So this Fall Safe project will look at, it's probably going to take about a year, but it's going to look at each and every aspect. And we're going to audit before, audit afterwards to check the improvement and see how it's going. The fall stickers and performer, I'm working with a few junior doctors on this, so we're also going to audit the falls reviews that happen. So we'll look at before, then we'll implement something like a sticker or a performer of what we want to happen in a falls review, and then we'll look at afterwards to make sure that we're getting the results and the reviews that we want, and then look at maybe if something like that needs to go out trust-wide. The other thing we've sort of pulled out, so I collect a lot of data, and within that data I've managed to find that repeat falls tends to be quite a problem within the trust. We get a lot of people that come in, and whether it's a fall, a couple of falls in one admission, or whether it's falls on multiple admissions, we need to be looking at these patients and recognising that this is happening so that we can, you know, use that information to reduce that risk. So if we just have a look at the next slide, you can sort of see here what I've done is, this is from the 1st of January in 2019. So you can sort of see there's a trend going up from the beginning of the year until about November. Then it does start to drop, but what we were seeing here is that there is a trend going up, and it's not really come down the way that we would like. So we're using this as how we are going to look at repeat falls, and what as a starting point, like a baseline, so that when we put an improvement in place, then we've got just one second.
Oh, sorry, just on a TV station for a minute.
Sorry, guys.
Bring me biscuits, I think.
Bring your biscuits. So we've got the baseline, so as soon as we do an improvement, we can automatically then see how much of an impact it's having, and it's just good to have all of this data and all of this these baselines that I've got for absolutely everything that we might be looking at in the Falls Safe module. Then it's all there ready to go. So the next slide sort of shows, it's a bit of a condensed version. I've done it monthly because obviously, sorry, this is weekly. So monthly is great because you can sort of see how things are going through the months, but I think weekly is also a beneficial thing to look at because you can see, although it has that sort of pattern of the one before, you can sort of see a bit more intensely that you have got some really high points along the way that you might have missed if you did monthly. So just looking at breaking that down further so that when we come to do our improvements, we can see where we've had the biggest impact, basically. So although not as many improvements have been done yet, there's a lot of plans for them, and there's obviously all of that baseline ready to go to see how things are working, which is going to be a huge benefit. So unless there's any questions, that's my bit.
Thanks, Sam. That was brilliant. Some fabulous work and brilliant to see some SPC charts in use. Have we got any questions for Sam? No, stunned silence. Brilliant. Thanks, Sam. And hopefully you'll come back and share with and you've got a little bit further and you can evidence that some of the improvements that you're going to test going forwards have made a difference. So
yeah,
it's great to have you back. But thank you so much for sharing.
Thank you.
So thanks, Sam. Research at the Royals COVID-19 story. Amanda and Victoria, are you going to talk us through this?
Yes. So I've not put the video on just because our signal is quite poor, but basically it's a story about the past year overall rather than just our COVID story, and we'll have two perspectives, mine and Victoria's. So just over a year ago we launched our 3-year strategy, which outlined our vision to create a culture where research is a welcome and expected feature of care in North Derbyshire, improving patient expectations and outcomes. Following the launch of the strategy, the Trust's merge with a research active primary care site brought its own challenges and distracted us somewhat from our usual business for a few months. Excuse me. Despite these challenges, when March arrived, we were thrilled to learn that we had achieved and surpassed our target of increasing recruitment by 100%, which felt quite remarkable. Around the same time, it was clear that COVID-19 was gaining momentum, and the hibernating pandemic studies that have been on our boards for years were coming to fruition. This is really where our COVID story begins. We're a team of dedicated individuals, always determined to find the answers to the research question, and these questions usually relate to care further down the line, but this felt different. This was immediate. We had to divide into COVID-facing and non-COVID facing teams, so red and green teams effectively, as some of the team were deemed to be at risk, including myself. The best way to do this was to physically divide. So myself and 3 other research nurses relocated from the research facility. The data managers worked from home, and those that could be COVID patient facing remained in the research facility. Once we started working on one urgent public health study, it was like opening the floodgates. They just kept pouring in. Myself, Tom Spencer and Karen Moxham had many socially distanced meetings to discuss our capacity and capability. In the end, we set up and recruited to 8 urgent public health studies, 3 of which were outlined by the Chief Medical Officer as the most significant. I believe we were one of only the few hospitals to do all 3 studies. When the team split, for me personally, it meant a completely different way of leading the team. My motto has always been, since qualifying as a staff nurse, never to expect anyone to do anything you're not willing to do yourself. I found it extremely frustrating not being by the team's side on the wards recruiting to these studies, and it took quite a while for me to adjust to that. I eventually found that I could lead just as effectively from afar. We had Teams meetings, socially distanced meetings in the nice weather, and phone calls. All in all, I believe that I helped create leaders within the team by empowering them and supporting them. Both teams had a significant part to play in all of this. Myself and the others in the green team contributed to recruitment by setting up a remote randomisation service for critical care. We also completed all of the outcome data for each of the studies, which was no mean feat. We also couldn't forget about the patients we already had on studies before COVID. These still needed study drugs and monitoring remotely during this very testing period. Meanwhile, the staff on the shop floor worked tirelessly to ensure all COVID positive patients were pre-screened for all studies. Part of the Red team consisted of a paediatric nurse and a nurse funded by Oxford to solely work on one extensive cardiology study. This individual had no prior acute medical experience. Despite this, these nurses absolutely stepped up and were vital to our success. Both Red and Green teams contributed to a 7-day service, which was a stretch considering the size of our team. What stands out in my mind from the last 6 months is that every single member of the team contributed to our success during the first wave of COVID. I feel incredibly proud of each and every member of the team. We all pulled together. Tom and Karen are not clinical, strictly speaking, but both donned a uniform and collected data from patients' notes. It was a real team effort that created incredible morale. I have to say that the last 6 months has been the most stressful but the most rewarding period of my 23 years of nursing so far. You will have seen that we've had lots of media coverage from radio interviews, that I've done articles in the Derbyshire Times and TV interviews have been held with Fergus Walsh. The media coverage regarding the results of the recovery study has clearly raised the profile of research to a point that we recently received a total of 70 application forms for just 2 posts. In the past, we would have been lucky to have received 1. Going back to recovery, it's quite amazing that our DGH, with a small research team, managed to double the average national recruitment. This is something we are incredibly proud of, as well as the fact that sorry, I've got a bit of a frog in my throat. As well as the fact that the results regarding dexamethasone from recovery were shared and put into practice so quickly. A conversation I will never forget was with a staff nurse recently that works on a respiratory ward, and she describes the moment the research team walked on the ward as being like a lighthouse, giving her and her colleagues hope that something could be done for their patients with COVID. She explained that when the admissions started pouring in, they were not able to provide the usual treatments such as AirVo, chest drains and NIV, and so her and her colleagues felt the only hope for their patients was the possibility of treatments via the clinical trials. This, for me, emphasises the power that research has. Without research, nothing changes. All of the research we do is so important. COVID research sees faster results, but it highlights how research should be integrated into everyday hospital business. The next wave of COVID will look quite different. Between May and the middle of October, I will have lost 4 experienced research nurses, thankfully due to career development, not because COVID research has driven them away. So a new recruitment strategy was needed. I've implemented teaching sessions for more senior doctors in the trust so that they can enrol patients with the support and coordination of the research team. And it's over to Victoria, I think.
Hello, thank you so much, Amanda. Thank you so much, everyone. So I will be talking about what we did on the COVID-19 patient-facing team and how we felt. The times that we've lived and that we are now going to experience in the next few months have been honestly probably the hardest since I've moved into this country, but for every single member of our team. And although Amanda wasn't physically here, I can honestly say that having a leader who was able to inspire a sense of shared purpose was fundamental. So I like to refer to this image that is on the screen now. So what Amanda was able to do is to share her why, so the purpose, why we needed to do what we were doing instead of what we needed to do first. And the way we did it was separating the team. So we had a process in place. We planned for the worst. Separating the team was a successful option, which helped maintain the motivation of each individual and gave purpose to every single member of the team. What we were able to achieve was offer a chance to a category of patients who did not seem to have one due to the lack of knowledge on the disease, and be able to be part of that was so inspiring for us that it changed the way we work and has helped us bring together the clinical and the research team. So what I really like about this is that the way we have approached things was leading in an empowering way, because we did it from the why to the what instead of vice versa. So by micromanaging the team, and in this, Amanda was really, really empowering from my point of view. We continue to develop different methods by which recruitment should have been successful. And the reason why our what sometimes had to change is because urgent public health studies are extremely difficult to plan as they continue to evolve due to the fast pace in which the public expects and needs result, of course. But at the end, we had to be resourceful, and thanks to a very innovative protocol, we were able to consent ourselves. So research nurses use their consenting skills for a drug study, which normally requires medics to do. The way we were able to do this was by developing an eligibility checklist, which we've used in the past and is been in the past appreciated by the MHRA already. And this was also shared with the wider clinical research community, as we were one of the few sites to have research nurses consenting. I think that this in itself was one of the most important steps in our COVID pathway as a research team, because thanks to this, we created a successful and an empowering environment for the nurses who were able to use their knowledge and their skills to their full potential. Also, it increased the accountability and professionalism by making the medics delegate tasks with confidence to a skilled team of research professionals. And in general, it felt like our effort had been appreciated by everyone overall. What I also like about Amanda is that you see we are very skilled in what we do. However, we are motivated even more than what we skills, because what Amanda has always passed on to me is that skills can be taught, but motivation can't, and she's always inspired me throughout my 4 years in research. Thanks to all the steps that have been put in place, we've been able to close the gap between clinical research and clinical practice. And we are now more than ever ready for making sure that this gap remains as close as possible. And all of this is actually inspired John Gardner and myself to write an opinion article on the possibility of expanding the skills of the research nurses and allow them to consent for all drug studies which have been submitted to different journals. We also have been shortlisted as finalists for their 30th anniversary of the Nursing Standards Awards, which feels incredible, of course. So in general, what every single team member and what Amanda, leading from a distance, has been able to do is create an environment, a very inspiring environment, in which I was personally able to do more, to learn more, and overall to become more, basically. And that's why she's a great manager in a great team. And if I was to summarize the research team in a few words, I would just say that we are successful, we are team players, we're accountable, we're caring and professional, and we lead in an empowering way, which is very, very important, and is what has actually made us go. Basically, we were scared, but we remained motivated. We were tired, but we were inspired, because we knew our why, we knew how to do it, and in general, we've achieved a very important thing, which was to offer a chance to every single patient with COVID. Thank you so much. If you have any questions.
Thank you so much, Amanda and Victoria. I think that's a brilliant message on so many fronts, isn't it? In terms of the profile and the work of the research team, but on other fronts too, in terms of a true reflection on leadership and how challenging that's been in the new world for some of us, how teams have had to adapt and find new ways of kind of connecting and working together. So it's brilliant to hear reflection on how you did that and how successful you've been, because I think there are things that translate across other teams across the trust. But any questions for Victoria or for Amanda? There's some comments about thought-provoking and congratulating you. But okay, so we'll move on. But thank you so much, and I'm sure we'll be talking about where research has gone again for the future before too long. I'm going to just quickly go through these, Victoria. So in terms of our improvement training programs, hopefully most of you will have already heard about our QSA programme, Quality Service Improvement and Redesign. We had to pause that back in March, but we're really excited that we're going to be bringing that back very soon. The cohort that were only completed day one back in March, we're hoping to bring back in a few weeks' time and restart that. So that's an accredited, CPD accredited 6-day programme that takes you through a national qualification. So it's a QSA programme, which is an NHS EI programme. That's all I'm going to say about it. So we've got dates going forwards. If you want to get in touch with us and find out more about that programme, we've got lots of people who've been through it and can tell you more. The other thing that we're relaunching shortly is our 1-day Introduction to Improvement workshop, and we're just currently going through the final refresh of this and making sure that it's fit for purpose, and we've taken all the learning from COVID and the new improvement approach going forward. So you will see a new refreshed Introduction to Improvement. Get in touch if you want to get involved with one of those sessions. It really is for everyone and is a really brilliant first step into improvement. We've had really good feedback and hopefully we continue to get that on the new programme. So I'm just going to go quickly through some sharing and celebrating good news stories, because that's how we always used to end the programme. So I'm not sure if anyone's aware, but this is new news last week. From my office, there was a big round of applause. Sorry. There's a big round of applause from the boardroom when the HR team found that we'd won the HPMA award for excellence in employee engagement last week. As Stacey's already talked to you about, Ashove Award are working with some new, I should say, cups which aid patient hydration and provide a link with home. If you go down to the den, you'll see that there's a makeover on the walls there for the benefit of our youngest patients. One of our matrons, Rani, has been nominated and commended for a British Journal of Nursing Award for recognising clinical excellence in nursing category. So congratulations to Rani. You just move on for me, Victoria. Thank you. So you've just heard about the research team, which is brilliant news and a really prestigious award. Our haematology team have also won a Fiona Littledale Award for thoughtful outstanding innovation in oncology. That's the second time we've won that award as well. Maria Ledbeater from the Information and Support Centre in the NGS unit won that award last year, so we're holding on to that one. We've got a newly launched video led by Mo Abdullah, our lead cancer lung consultant, about our straight to test CT pathway. So we've significantly reduced the diagnostic phase, and what used to take 3 to 14 days can now happen on the same day. And there's an information video on YouTube to take patients through that, and so they understand the pathway they're going to follow. Next slide, please, Victoria. So staying on the video front, our lead cancer clinician, Iman Azmi, has been also producing a new video around our self-management for breast cancer follow-up pathways. We've got really brilliant feedback from patients on that. Our annual members meeting went virtual, and there was lots in there celebrating our improvement success. So if you've not had a chance to have a look, please have a look, and it's on YouTube and you can catch up and find out about the celebrating of improvement for the last year. And then our Derbyshire Children's Continence Service as well, which is a partnership between ourselves, DCHS and DCHFT, have been shortlisted as well for 3 Nursing Times Awards. So we've been doing brilliantly on the awards front, and we want to keep that success going. Next slide, please, Victoria. So that's just me to say thank you. It's been an absolute pleasure having you join us. If you could share and get people to catch up on this But if they weren't able to join us live, we want to learn from this. I'm already kind of taking loads of learning about how I think we can develop this going forwards and get more interaction, which is always a challenge for us when we're not all together in the room. So please let us have your feedback. It's really important to us, and we will learn in doing these again for the future. But it's been a pleasure to have you with us. If you have any improvement ideas, we'll leave our details on the screen there for a while, and we hope to see you next month. Thank you, everybody.
Maria?
Yes.